his district. It's a zip code level look. We can actually look at it aggregated and so rank him against the rest of the city. And this is actually drawn from the diabetes index. And so if you went on there, you could pull this data up for him. And what you're seeing is that within his district, these areas right here, 14% or higher of the population has diabetes in these zip codes here. That's pretty significant. That's actually up there with the state of West Virginia. West Virginia sort of, all of West Virginia sort of looks that way.
Only black and brown.
This one right here, I just pulled blacks, but it's pretty much the same thing. It's really quite high. I mean, we could do it quickly. I haven't ranked you against everyone else in the state, or the country, but certainly we could do that. This is the uninsured. So basically what we're saying in his district, somewhere between 13 and 17% of the diabetics have no insurance. So think about that for a second. Now, you've got diabetes, and it's going to cost you about $12,000 a year to manage it, and you don't have any insurance. You're just going to, I mean, first of all, you can't afford, if you can't afford insurance, you can't afford to pay for diabetes. And so that's the beginning phase of health disparities. You get diagnosed whenever you went to the doctor with diabetes and you're uninsured, and so that's kind of what it looks like. So he's got a significant number of diabetics there. Hemoglobin A1Cs. So what the literature says is that your hemoglobin A1Cs, if you're well managed, there's some argument among experts about hemoglobin A1Cs, but let's take it at 7 or below. Means your diabetes is under control. And so what we're saying in his district, somewhere between 22 and 34% of the diabetics are uncontrolled, have diabetes that's uncontrolled. And within that, and again, we're looking at blacks. And if we segmented it out by age, we'd look at that population 44 to 64, and somewhere over 50% of them have hemoglobin A1Cs, with the older population, those in Medicare, having greater glucose control than that middle population. And in that 44 to 64, that's where you're going to see the hospitalizations and the mortality and the amputations and going blind. By the time you get to 65, you're in the survivor pool. It means you behaved yourself and you got to live and make it into Medicare. That's essentially what it means. Point being, 50% of black males die before the age of 65. 50% of black males die before 65. That's disparity. That's what we're talking about here. This is an important number. This is that, remember that avoidable hospitalization that we're talking about here? Well, this is the face of avoidable hospitalization in his district. So what we're saying here, of the diabetic population, these are blacks. In this red area here, over 52% of them are going to the hospital. That's a big number. That's a big number. That's a lot of hospital encounters. And these are actually hospital encounters. So they're either going to outpatient emergency room or they're going for inpatient stay. And about 67% of those who go to outpatient are kept overnight. So those are really big numbers. And you can see you have some variations. I don't know his district very well, but you can see the variations up here. Maybe, I mean, we could go back and look at some point. Maybe more affluent segment of his community up here. Yeah, that would be my guess. Yeah. That would kind of explain what's. But even here, look at the hemoglobin A1Cs. Even though, and we see this, even among the affluent, you're not seeing tremendous glycemic control, which is an important issue. We see that all over the place. So this is the uninsured diabetics in California. California, healthcare reform was written for California and Texas. It has got the largest number of uninsured people in the country. And so I don't know why you guys aren't in the streets, protesting and fighting for Obamacare, because your uninsured population is really quite significant. I can't remember whether Texas is first and you're second, but whatever it is, it's pretty doggone close. And being ranked with Texas uninsured is not where you want to be. I can tell you that much anyway. But that's where you can see the variations around the state in terms of, these are diabetics. So you can see you've got big numbers of diabetics here. And this is by upper house. So some of your colleagues, particularly in this area here, need to understand that diabetes is a significant, uninsured diabetics are a significant part of their constituents. And obviously, if we went in, we'd see the hospitalization costs and everything else that is attended. Again, we're shaping up and talking about the minority healthcare market. So nationally, what we know is that by 2050, 50% of the American population is going to be minority, right? By 2020, 40% of the population. But look at this. This is medical expenditures, right? This is all medical expenditures, and I'm comparing whites against all minorities. So right here, right, 2000, a little over 80% of every healthcare dollar in America was spent on whites. 80%, right? The population starts to move down. As you can see, by the time we get down to 2005, the white population is about 62% over here. But look here, still, over 75% of every dollar in the United States, $2 trillion, right, is spent on whites. That's the face of the disparity. That's the consequence of not being a consumer in the marketplace, right? And here, what we're looking at is per capita spend. So here, what we're saying, per capita, we're spending about $4,000 a year on every white in the country, basically. African Americans is about $3,200. Hispanics, we're not quite spending $2,000 a year on their care. That's the difference in consumer. That's what I'm talking about when I'm talking about consumer access and the ability to be in the market. So this is California. So this is the Hispanic population by 2030. You can see the tremendous growth. This is the white population sort of flattening out. You're seeing some growth in the Asian population. So that's the diversity. I think that's really important. You guys are at the cutting edge. You're at the vanguard of what America is going to look like in the 21st century. So what you do around healthcare, how you handle diversity, is a lesson that the rest of the country needs to emulate. In the same way that people sort of scratch their head and talk about Massachusetts and what they did in terms of the mandate and how well that's working in the example, California has that opportunity around diversity. And it's not just the United States. The world is coming more diverse. If you follow what's going on in England, they're grappling with the whole issue of diverse populations. So you've got an opportunity here, not just to lead the nation, but to lead the world on this issue. I wanted to, again, sort of help you understand this whole issue of consumerism in healthcare. So this is actually a study we did for a company. We're looking at total hip replacement in California in 1997. These are the total number of hip replacements in California. This is what was paid by Medicare and Medicaid. And by the way, we can map this all the way down to the zip code level. So I'm just giving you aggregate numbers, and here's private insurance. Look here at blacks, 4% of all the hip replacements. Look here at Hispanics. And look at this little number here for Medicaid. That's what I'm talking about. That's what Medicaid does, right? That's what Medicaid does, right? And this is not to say, and I'm not showing you the other set of numbers, looking at the prevalence of osteoarthritis. I mean, the prevalence is high in the minority community. They're just not getting treated. And this is best modern therapy. I know I got one myself in terms of hip replacement. So that's 1997. And if you remember, the white population is up here in 1997, right? So now let's jump forward and look at 2007. So the white population in California has come down. It's around 50%. But look here, 81% of the hip replacements in California is still whites. Look at African American. Look at Medicaid. Go back here to 97. Basically the same number. Remember when I told you about consumption patterns and how they're stable? Well, that's the consumption market for total hip replacements in California. And let's just pop forward. This is 2010. And guess what? The world hasn't changed. 5%, 81%, and look at this number here. So when I look at a client who's in the market for hip replacements, I say to him, your market's actually shrinking because you're not recruiting and getting this best modern therapy to the majority of the people in California. You're only working with the minority population in California. I'm sorry, but they are the minority population, but they're getting the majority of the therapy. That's why those numbers look the way they do. We could do this exercise for diabetes. We could do it for stroke. We could do it for AFib. That's the state of health disparities. And so when people tell me about consumer behavior, so the rumor that's out there is that minorities don't want to get hip replacements because it's a cultural thing, that somebody wants to run around with pain, so yeah, it's a cultural thing. No, it's because right here, Medicare, you got to pay 20%. Medicare pays 80, you pay 20, can't afford it. It's about a $50,000 operation. Medicaid, forget it. Basically, we ain't doing it for you. Private insurance, you get more of it, but still minorities are underrepresented. So the challenge for us is we have to figure out a way. We're not going to do anything about health disparities as long as we have this huge population of minorities, the majority of the people in California, I might add, who don't have access to the healthcare market. That is the big question. And so my final recommendation to you is, if the court does what everybody seems to think it's going to do, and I don't understand why they're doing it, because we went through the market fundamentals. You have to buy health insurance. Government has to help be an insurer because the private sector can't do it all alone. And so causing everyone to buy health care is stabilizing the healthcare market, both in terms of getting people access to care, but also building the innovation and the products and the technology that can get shared broadly. So it really does make a lot of sense to do. But if they decide not to do it, I think California has to do that. I don't see how you get around not getting mandates in place and getting all of these people insured. There's no way to change these health disparity numbers without doing that. It's going to take that sort of initiative to get it done. Thanks.
Let's again thank Dr. Norris, Dr. Puckman for their comments on the disparities. We're going to shift the discussion now, though, to agencies and healthcare providers. Specifically, we want to focus in on what California has done after the Institute of Medicine report was released to ensure that the disparities did not continue. Obviously, we've not had much success, but we're going to hear from Dr. Neil Kohatsu, the Medical Director of the Department of Healthcare Services, for his insight and for his comments. Doctor?
Thank you, Senator Price and distinguished guests. I really appreciate being a part of this panel, this briefing. I think we've had great presentations that are going to inspire us and give us some specific policy direction as we work together with the administration and the legislature as well. I'm going to streamline some of my comments in deference to other speakers that I want to hear from as well, but I'll try and focus in on what we need to do. As Senator Price said, the overall picture is that clearly not enough has been done to address disparities. I'm going to focus in particularly what the Department of Healthcare Services is going to do about that so that we reach that vision that you talked about. So 10 years from now, we say, what have we accomplished, not what further work needs to be done, but how are we going to get the job done? So just by way of background, the department used to be called, there was a Department of Health Services which split into two departments in July of 2007, Department of Healthcare Services and Department of Public Health. And the reason I bring that up in the way of history is that in the Department of Healthcare Services, we focus in the healthcare environment. Department of Public Health is more population-focused, and I'll talk a little bit about that. So I'm going to focus on the Department of Healthcare Services. The Office of Multicultural Health was created by state government in 1999, the Office of Women's Health in 1993. I bring those two offices up because Governor Brown has proposed creating an Office of Health Equity. My colleague in the audience noted that health disparities apply not only to race, ethnicity characteristics, but also age and gender. As Dr. Norris said, the social determinants of health are very important to address disparities. So the Office of Health Equity will be looking at health disparities with respect to multicultural health, race, ethnicity, gender issues, social determinants of health, and other factors, including age and rural-urban differences, and that's a proposal that he has made. My position as medical director didn't exist until a year ago in March, and so that's why I'm focusing on what we're doing on a go-forward basis. I think Dr. Puckren has clearly laid out, to be able to address disparities, particularly racial, ethnic disparities, you have to have a foundation of data, and he's given us two great talks highlighting not only at the national level but in California some of those disparities. We are just getting, I think, to get our data act together in the Department of Healthcare Services to focus and be able to do the kinds of reports, including ultimately mapping, that will allow us to say within the Department of Healthcare Services, and as you know, we oversee the Medi-Cal program, to be able to define in detail the characteristics of those disparities by focusing, basically creating a clinical informatics group within the department. Some of the data sources that we're going to use are the California Health Interview Survey, and literally I talked this morning with staff about looking at differences in prevention and lifestyle. I think Dr. Norris mentioned that there are dramatic differences, for instance, in the smoking prevalence from a low of around 5% in Asian American women to over 50% in some Native American subgroups. So that's data from the California Health Interview Survey. I think Dr. Norris also, and I think Dr. Puckren as well, alluded to the importance of being able to do modeling to look at the impacts of what would happen if we could eliminate some of these disparities, and we're using a very sophisticated modeling package we just got access to called Archimedes to, in fact, do that, to see what is the potential if we're able to deliver these interventions. The value equation is very important. Dr. Puckren talked about the need of having expanding access. We have about more or less 7 million uninsured of a population of about 38 million Californians, and so with the Affordable Care Act, we'll have about 2 million to 3 million more members in Medi-Cal and about 2 million more members through the health benefit exchange, and so there will be many more through ACA, assuming that all of this is sustained by the Supreme Court. Many millions more of Californians will be in the marketplace that Dr. Puckren alluded to. Finally, I want to close with focusing in on what are we going to do within healthcare services, particularly to hone in on disparities. And I want to highlight that we are working with a framework that is in the Affordable Care Act, about 3 linked goals, and both speakers talked about this. The 3 goals that we're focusing on in DHCS are improving the health of the population of Californians, particularly those served by DHCS programs, enhancing the quality, including the patient care experience for those members, and reducing per capita costs, and that will allow us to put more money into what is effective. And again, as Dr. Norris said, some things are overuse which are less effective. The 7 priority goals are, number 1, eliminate all health disparities, particularly those related to race, ethnicity, gender, poverty, and age, among others. That's one of the 7. Improve patient safety, and there was a discussion of, in fact, again, an area of disparities. Improve patient safety. Engage persons and families in their health, and again, both speakers alluded to that through social networking and other new strategy. Improve communication among providers, and one of our colleagues talked about using distance, bringing together providers through electronic health records and also through telehealth, and that's one of the strategies that we also embrace. Promoting prevention, fostering healthy communities. Again, Dr. Norris talked about this in detail. And developing effective, efficient models of care, medical homes, systems of care, reaching out to those who are with very complex care issues, and targeting them for the special services that they need. So those are the 7 priority areas that we're envisioning in our quality strategy, and I gave you the 3 goals. And so I found the presentations to be very instructive. We're going to use that in our thinking as we refine the quality strategy and working with our partners in government and other stakeholders, because no one can do it alone, private sector nor the public sector, and all channels of government need to work together. So I look forward to the other 2 presentations and how we can work together again on eliminating disparities. Thank you, Senator.
It does have to be a collaborative effort. Reference was made to the public sector and private sector. We're going to shift, getting the perspective of the private sector, Kaiser Permanente. I happen to be a card-carrying member. And we have with us Angela Jenkins, Community Benefit Manager, to share with us the Kaiser way.
Well, thank you for inviting us, Senator Price, to present at this hearing. And I just want to say it's my pleasure to be here with you today to talk about Kaiser Permanente's work and the work that we've been doing in the community. We have a very long history of innovation and attending to the unique needs of the populations that we serve through our hospital centers and in our communities. And we have a number of internal programs that we offer to our clinicians and our staff that focus on disparities and reducing health disparities, providing educational opportunities that promote awareness among our membership, among our staff, and through our diversity work that we have at the national level in all of our settings, and through many of the clinical trials and the research that we do. It's an opportunity for us to create awareness and to learn about health disparities and how we can change our practices and our clinical practices to address some of these issues. We also believe that most of the work that we do to reduce health disparities can't happen just in our clinical settings, and that actually has to happen in the broader community. And in doing that, we have actually created a very robust community benefit program, community investment program, where we provide grants and donations and leverage our internal programs to support community-based efforts to address many of the health issues that we talked about today in the other presentations. And we do that through 4 main streams of work: providing care and coverage for low-income people. Much of this is around providing care to uninsured populations, but it's also was an opportunity for us to develop a health insurance product for children who are uninsured and who don't qualify for government-funded programs. Developing and disseminating knowledge, which is the Division of Research, which I mentioned earlier, but also our educational theater program, which some people may have seen if they have children in public schools. The educational theater program, it's actually, we have 5 theater programs where we actually hire trained actors to go into schools to talk about health issues. And also through our residency programs. Someone mentioned earlier about residency programs. We actually have residents that provide care in community clinic settings so that they understand what's happening in the community setting, and they can bring that knowledge back into our organization. And 2 I'll focus on today are our partnerships with Safety Net, and also our community health initiatives, which is a Healthy Eating, Active Living initiative that we've been funding since 2004. I have it right? Oops, I just turned off. There you go. Not sure why. It's the top button, right? This button right there. Okay. There you go. Okay, thanks. So Kaiser Permanente in the community, why do we invest in our communities? Well, it's a core to our mission. Part of our mission statement says that it's to improve the health of our members and the communities that we serve, so really looking beyond our walls and looking at the broader community. It's essential to our nonprofit status. Kaiser is a nonprofit organization, and we believe that community-based prevention and preventative care make our communities healthier and actually contributes to lower costs. We all know that prevention works towards lowering costs later on in life when these issues become more prevalent. And we're committed to eliminating health disparities. So we have a history of community health, and this is actually a picture of a noon hour health education program at the Kaiser shipyards in Richmond several years ago. And this is actually a physician talking to workers about preventing the common cold or what they need to do if they were to get a cold. And so we like to show this picture just to show that historically we found that it was really important to provide information to communities about how they could care for themselves. So our vision around our community benefit programs is that Kaiser will play a leading role in improving our community's health. And leading role is really significant there. We really see ourselves as a leader in this area, really focused on low income and underserved populations, so that everybody has access to vibrant communities and access to safe places to play, access to parks and schools and healthy food. And we aspire to eliminate health disparities by working in partnership with our communities and directing the assets that we have of our organizations in a targeted way. And my role as a community benefit manager, I'm actually located at the Oakland Medical Center, and I serve Oakland, Berkeley, and Richmond. And so I'm actually working directly in partnership with community-based organizations, working with community clinics, working with collaborative groups to address a number of health issues that come up in those communities. Part of our assessment work that we do to identify how we invest in communities is we actually conduct a needs assessment every 3 years. It's actually required by law, SB 697, that we do that. Part of that is working with public health departments to collect quantitative data to identify what the needs are in each of the communities. And we do that in Alameda County has a great data set and great report that shows whether or not health conditions are changing or not, and they do the GIS mapping that we saw earlier to show where the prevalence of certain diseases or conditions are in the community, so we can target our efforts to those communities and those individuals. I also manage a local grants program, and the assessment process helps me identify who and how we will serve them. I actually have a local budget that I am able to invest in local communities, and we partner with faith organizations because we recognize that they can be leaders in the community around these issues. We partner with community residents. We actually conduct focus groups with specific populations by language, by ethnicity, to identify the needs, and I think that's really key when you're trying to focus on disparities, because it allows you to identify who you want to serve, how you want to serve them, what age you want to serve, and you can really be strategic in your investments in the work that you do, and you can shape programs around that. So one of the initiatives that Kaiser has taken on actually nationwide, we have 3 layers of our organization. We have a national presence, we have regional presence, and then we have our local presence, as I mentioned earlier, is our Healthy Eating Active Living program. So in 2004, we established this initiative, and really it was established because clinicians were saying, you know, I'm working with a patient, I'm providing them advice and information on how they need to care for themselves, but once they leave our doors, the community doesn't have the resources and support that they need to be able to maintain their health. It really was a way to take the focus off the individual and really look at the broader environment. What is happening in the broader environment around where these people are living? Do they have access to grocery stores, or is it a liquor store? Do they have access to a clean park that doesn't have needles in there, or is violence happening in the community? What's going on in the communities where these people are living? So we funded three communities in Northern California, 3 collaboratives, the first phase, to focus on changing environment, increasing access to healthy foods, fruits and vegetables. And the pictures that you see here is where in one of our communities where they saw this area where people couldn't walk because there wasn't a sidewalk, and they did some advocacy through the collaborative, and they were able to create the picture on the right where you have a sidewalk and a sign that says people are crossing so they don't get hit, and planted some trees, but it actually created an opportunity for people to get out and be physically active. The bottom one, I believe, is in Richmond, California, where this was a storefront. And so after the work that we did, they actually were able to work with the owner and get some healthy foods that were present so people could actually go by and purchase them. So really changing the environment to make it easier and actually attractive to go in and actually purchase these foods. So since 2004, we actually have expanded the initiative. We're now in 7 communities, and we have local partnership grants, and we've invested $21 million to support these efforts. And this is important because while we want to make sure the environments are healthy so that they're not ending up in the safety net, not ending up in the hospital later on in life with some really serious conditions. So the other one is our partnerships with our safety net and our community clinics and public hospitals, which is really the focus of what we're here to talk about today. And we believe that our safety net partners are an extension of the work that we do. We couldn't do what we do without them. We value the work that we do, and we thought that it was important to create opportunities for partnership through investments with them, but also sharing some of our clinical guidelines and practices with them that we have learned through our research and work with our own members. Knowing that it works, why not share it with our community clinics so they can do some of the same things? And so what I'd like to do is actually show you a video of a clinic that we're working with where they've actually been able to institute some of our protocols in their practice, their care practice. Can you? And then if you click the arrow again in the middle, there you go. Mm-hmm. And then you can expand it if you want to.
Feel respected.
If it wasn't for Lifelong, I would have died.
Gwen and her family are a perfect example of what Lifelong means to this community. We serve lots of uninsured folks. We serve about 22,000 people per year.
I have COPD, diabetes, high blood pressure. I suffer from high cholesterol. I'm on oxygen therapy, and all my needs are being met here.
Gwen and Bruce have been my patient for 6 or 7 years. Both of them have undergone really pretty significant medical crises since they've been my patients. For Bruce, it was life-threatening pericarditis, where his heart almost stopped beating.
I hadn't seen a doctor in maybe 10, 15 years. So I was really glad to get in there.
Suffering from chronic medical issues, severe medical issues, and poverty at the same time is very, very difficult.
Lifelong is the place where people go who really need health care and don't have other options. We count on people's help in our community to make that happen.
The safety net is just spread incredibly thin, and I would be seriously worried, especially for Gwen, for her health if we were not here.
Kaiser has really made an effort to partner with community health centers around the state of California. Right now, we're partnering on some of our health disparity work with Kaiser to try to reduce cardiovascular-related disparities, particularly in the African-American community here. Kaiser's been a tremendous partner in that work. Lifelong and Kaiser see the health of their patients, their members, as really a community health issue and a prevention issue. And that's a tremendous thing in a partner for a community health center.
I see my patients in the schools, in the supermarket. We all live together and we all impact each other. So I think it's really important to take care of the health of all our community.
So it's a really good example of how we've been able to really support a community clinic in the provision of care. And so I was really pleased to be able to show that to you today. And since 2004, our investments, financial investments in community clinics have gone over $10 million. And we've invested in specific interventions around health information technology. We've provided about $4.5 million in grants to help our community clinic partners develop electronic medical records and health registries for their patients. We've also done a quality improvement initiative, phase, which I'll talk about in a minute. We've provided grants to statewide collaborations to do advocacy around the safety net, what's happening with the safety net clinics and healthcare, particularly as it relates to the populations that they're serving. We've also provided grants to them to enhance and support the delivery of specialty care in the community clinic setting. And then the other project that we partnered with them on was PHASE, which is preventing heart attacks and strokes every day. This is actually a practice that we established within Kaiser, and it's really about a straightforward combination of medication and lifestyle changes for patients who are suffering from, who may suffer from heart attack and stroke. And so we've been able to share this protocol with 63 community health sites throughout California, touching over 27,000 high-risk patients who have benefited from this intervention. Knowing that heart disease is one of the #1 killers in the community, we found by using this evidence-based targeted intervention that we within Kaiser were able to reduce the death from heart disease so significantly that it's no longer the #1 cause of death within our membership. So we said, well, why not share this with the community clinics? Why should our members just benefit from that? So we agreed to share it with our public hospitals, community clinics. We bring them together periodically throughout the year. They have partnerships with individual clinicians within our facility. We have conferences with them in partnership with our safety net providers, so we can share best practices and we can learn from them about what they're experiencing and provide technical assistance on actually implementing this, but also some of the information technology work that they're trying to do in the clinic setting. And so we wanted to share this with you to show that we as a large organization are able to leverage a number of resources, our clinical expertise, financial resources to have impact on the community, not only in the clinic setting, but also in the broader community to prevent individuals from having to receive greater care later on in life. And so it's our great pleasure to be here today to be able to share with you some of the programs that we've actually been able to implement.
Any questions for Angela? Okay, we're moving into our last, I'm sorry. Oh, Mia. Thank you, Angela. Okay, we're going to move into our last panel, and I think appropriately called Community Testimonies. And we have Dr. Barbara Nash, who's been in family practice, who's been working with the American Heart Association, I believe, and who is a very knowledgeable practitioner. We're happy to have you here, Dr. Nash. The floor is yours.
Good afternoon, late afternoon, I think. And I won't keep you long. I know most of you are pretty tired by now. I want to thank Senator Price and members of the caucus and guests for inviting me to speak on such an important topic. Am I getting there now? I'm Dr. Barbara Smith Nash, and I've been a long-time volunteer for the American Heart Association especially since I retired about a year ago. And I was practicing for UC Davis for the last 30 years in family medicine, and I was associate professor in family medicine, and I was one of the only ones here in Sacramento that also did OB and family medicine. But since my retirement, I've volunteered even more so with the American Heart Association, and with the American Heart Association, it is really we're really aware of health disparities in especially the African American community here in Sacramento. My job has been to go out in faith-based community, the churches, and also in health clinics that different organizations have, to help educate them about heart disease and the power of stroke. We talk to them about cardiovascular disease, that it's the #1 killer of Americans, and it's disproportionately toll on many racial and ethnic groups. I would like to highlight some of the more sobering statistics, and I know today you've heard a lot of statistics, and these may be duplicated in some. Cardiovascular disease accounts for about 1/3 of the disparity in potential life years lost between blacks and whites, and earlier you were shown that. Cardiovascular disease age adjustment death rates are nearly 34%, higher for blacks than the overall U.S. population. Blacks are nearly twice as likely to have the first stroke and much more likely to die, to have the first stroke at an earlier age, and much more likely to die from that one stroke than whites. Heart failure before age 40 is 20 times more common among blacks than among whites. American Indians, Alaskan Natives die from heart disease much earlier than expected. 36% are under 65, compared with only 17% for the U.S. population overall. High blood pressure, as we know, is more prevalent in certain racial and ethnic minority groups, especially among blacks, for whom the prevalence is the highest in the world, and it's increasing. Non-Hispanic blacks and Mexican Americans have a higher prevalence of diabetes than non-Hispanic whites for adults over age 20. Racial and ethnic minority populations also confront more barriers to cardiovascular diagnosis and care. They receive lower quality treatments and experience worse health outcomes than their white counterparts. Such disparities are linked to a number of complex factors, and some of them have been explained to you today here, such as income, education, genetics, physiological factors, and access to care, and communication barriers. And here I'm going to talk about what has happened in my practice. As I said, I have been with UC Davis since I graduated. I did my residency in Fresno, which is Central Valley, because that's where I was initially from. And in my practice here at UC Davis, I had a practice where I worked for UC Davis part-time and then had a private practice. But because of Medi-Cal, I wasn't able to make a living. So I left I left the private practice and, joined the UC Davis faculty, fully. But during that time that I saw those Medi-Cal patients, and this was in the late 80s and early 90s, what we saw was happening is, as I think Dr. Norris explained, or Dr. Huckins explained, is that we were trying to increase our numbers of seeing Medi-Cal patients just to make the basic, payroll, basically. So therefore, some of us were not able to do it. So when I became a full-time physician and a professor at UC Davis teaching family medicine, there was more a diverse population. But because I was an African-American female, my population was weighed heavier with African-American patients, especially women. And in the Sacramento area, that was hard to come by. And the one thing that we had, I was out in the Elk Grove area, and we had 5 African-American physicians in one facility, and nobody could figure it out. I was the only female, and there were 4 other men. So they were coming from all over Sacramento, the African-American patients, just to see us. And in doing so, we did a lot of education with these patients. We were able to reach out to them. And one of the clinics that we had that we were able to get educational materials out to was the Imani Clinic, which was run by UC Davis. And I was a co-founder in one of those clinics, where we would serve patients who had no insurance. They were charged nothing, and the drug samples that we were given were handed out to these patients. But the problem was, as we talk about disparity, was further access. We could diagnose them, find out they had diabetes, tell them that they had high blood pressure, tell them that their EKG was abnormal, but where did they go from there? And that was a problem. We could send them to the county clinics, but then they, because of funds, started to shut down. Then they would end up in the emergency room, and we know that's what part of this health reform is all about, because who pays for the emergency room patient? We do. And that's what people don't seem to understand. You know, they don't want health reform, but they want them to go to ER, and yet our tax dollars are paying for them. So that was one of the bigger problems that we had, was access after being diagnosed. But the American Heart Association has tried, through their education, to improve the cardiovascular health outcomes of a diverse population through targeting preventive health information and health care, to provide in a way that they were able to understand what's going on. When I would talk to them about what's your numbers, they didn't know what a BMI was, and I had to explain how important that was. When I would tell them why it's important to signs of stroke, they didn't know what that was. Yeah, my sister had a stroke, or my grandma had stroke. How does this affect me? We had to explain that. And through the American Heart Association, we've been able to do that. So a person's race or ethnicity should not put them at a higher risk for developing chronic disease, such as diabetes, hypertension, and cardiovascular disease. But as you've heard today, it's unfortunate. It is one of the factors that affects a person's likeliness of suffering chronic disease when there's no access to health care, when providers are not available, whether they be ethnic providers or whoever. And heart disease and stroke are the 2 diseases that affect us the most. And when I talk to a patient about heart disease and they have diabetes, this is what always gets their attention. I say to them, if I was to take your heart out right now and look at it, and you're a diabetic, you've already had the first heart attack. Then they listen. What does that mean? And then we have to explain. But through the American Heart Association, we've been able to reach out to those who are uninsured, who are in the communities that have no provision for health care. And we are continuing to do that. The American Heart Association is committed to reducing health disparities in the United States through preventative programs and ensuring access to quality health care for all. Thank you.
Any questions for Dr. Nash?
So she's a very good example of African American physicians that carry a dialogue with patients, especially I was her patient at UC Davis Medical Group in Elk Grove. So she's just a very good example and something that we should take as a model of educating other physicians about doing this and being real role models for their patients and carrying this style.
Thank you. And I want to thank all of the participants for their participation. Dr. Puckrin, Dr. Norris, Dr. Kohatsu, Dr. Nash, and Angela Jenkins. You all have certainly provided us with a wealth of information. We know there's a lot of work to be done, but it's clear that there are professionals who are committed to the job, and certainly you can count on the legislator, the California Black Caucus, to partner with you as we try to navigate these health care problems and obstacles and opportunities. As was mentioned, the health care reform that's currently being debated in the Supreme Court is a powerful tool. And if it is struck down, we're going to have to find something to replace it. It's not that it's going to go away and all of our problems are resolved. I mean, this health care discussion and debate, I think, has sort of picked the scab and made everyone a lot more aware, a lot more conscious, a lot more sensitive to what the issues are and what the responsibilities are. And so this is, as we suggested earlier, is one in an ongoing series of conversations that we're going to be having on healthcare disparities, how we address it, how we equip ourselves to deal with it in the future. We're going to be having a series of town hall meetings, conferences, discussions like this to better educate, better inform, and better prepare ourselves. And so we want to thank, again, staff for the work, paid and unpaid staff, for the work and pulling this event together. Again, appreciate all the panelists, especially Dr. Puckrin and Norris, who joined us from out of town. And again, we just appreciate, as we close, let me just acknowledge our vice chair, Assemblymember Mike Davis. And again, while this is the conclusion of our informational hearing, it's not the conclusion of our discussion, just the beginning. We look forward to engaging you, collaborating with you, and working with you as we try to find the right kinds of solutions and the better approaches to solving these problems. So if there's no other business, this informational hearing is adjourned. Again, thank you.